Okay. Uh, Welcome all on the behalf of Spine Society Delhi chapter. I welcome you all to our education program. That's the master series on spine, where we discuss every month, second Wednesday, for 1.5 hours, a very specific topic dealing with all the aspects of that with our Delhi Spine Society faculty and a national and international faculty and experts from around other fields. So today's topic is very dear topic which all of us manage, that the spinal tuberculosis from tradition to technology. And we have great experts on that who will be taking up different topics on this. Dr. Sunil Kotoch, he is a senior consultant at the Max Saket Hospital, New Delhi. Professor Tankesh Barua is a spine surgeon at Safdarjung Hospital. Dr. Guru Raj, who is the coordinator for this meeting, is a senior spine surgeon at the Indian Spinal Injury Center. Uh, Dr. Anvita and Dr.
शुरू कर दिया क्या?
Atul Gogia are our infectious disease department heads at the Gangaram Hospital in New Delhi. And Dr. Ajay Shetty, who is the president-elect of Association of Spine Surgeons of Delhi, India, and a senior consultant at the world-famous Ganga Hospital, Coimbatore, will join us shortly. Uh, Unfortunately, Dr. Bajaj could not come because of bad viral, which has hit us, most of us in Delhi. So has Dr. Anil Jain. So we'll cover up those topics. And Dr. Katoch has finally pitched in last minute to take up Dr. Bajaj's topic. With this, Guru can go through and explain how we go about for today.
Yeah. Good evening, all. Once again, we welcome to this Delhi Spine Society's masterclass web series. And today's topic is tuberculosis spine. And we will have 10 minutes talks. And at the end of the session, we will take questions together. And you can all have questions in the chat box. And then because we are going to cover most of the topics one by one, so if anything is left over, we can definitely take it up at the end of the session. And I would request all the speakers to stick on to the time. And I invite for the first talk Dr. Rupinder Chahal to deliver his first talk.
Thank you, Guru. My slides are visible?
Yes.
Okay. Thank you. And I will begin up with an important aspects of spinal tuberculosis as such and how we've been doing about it. So important question is one small rod like bacillus, 2 to 4 micrometers, 0.5 meter in diameter, has created havoc. So why do we talk about it? Because it has brought in more mortality and morbidity than any other disease. Every 15 seconds, someone 15 seconds, someone in this world is dying of disease.
मतलब बाहर निकल गया?
Guru.
Oh, sorry.
No problem. Okay. Every second, a new person is being affected. So globally around it, this is 4-year-old data, 9 million TB cases occur annually, where around 46 lakhs develop MDR. 1.2 million die and 2 million cases of TB new cases are added in India. So in India, 20,000 are infected every day, 5,000 develop disease and 1,000 die. So if multi-drug resistant tuberculosis and extensive drug resistant TB was a tragedy in making, total drug resistant has made us helpless. So if you look at the share of India in this is around 26%. So all the high burden countries contribute more than 60% of the world's load, and these are just 8 countries. So this is the problem limited to few. MDR, it's increasing incidence. 3% of the new cases are MDR and 17.7% of previously treated turn into MDR. India, China, and Russian Federation contributes up to nearly 50% of the MDR or RRTB in the world. So what are the risk factors? We already know malnutrition, HIV status, alcohol, smoking, diabetes, crowded places, immunodeficiency, drug users, elderly, all are at high risk. And among them, the alcohol users and the HIV contribute significantly. All of us have gone through, the government has been quite active, and WHO has started its end TB strategy from 2016 to 2035. So, what are the milestones and what are the sustainable development goals which we look at it? So, they looked at the reduction in number of TB cases by 2020 should be 35%, 25, 75%, and end of 35 must be 95%. Similarly, reduction of incidence rate and the TB affected families facing catastrophic costs due to TB should be zero. The family should not be spending anything. So now everything is free by the government, and even government pays the patient some money. So where have we reached? So reduction of deaths only 14%. The target was 35%. Reduction in incidence was uh, supposed to be 20%, so it was only 19%, 9%. Indian scenario, we have looked at its 18 cases notified. Decreases was due to the impact of COVID in 2019. So the cases rose up to 24 lakhs. The treatment was started for 95% cases and success rate was around 82%. MDR has been on the rise in India, and now we are detecting lot of XDR cases also. Historically, it's the oldest recognized disease of the mankind, found in our old Rig Vedas and Egyptian historical mummies. Uh, in changing times, its prevalence is no longer restricted to low socioeconomic status. But even in the past, the history tells us that King Tutankhamun, Mrs. Roosevelt, the poet Keat, all fell prey to this. So this is important now. Your patient walking into your OPD with tuberculosis is no more a slum developer. It is a rich person coming in a big car, and they get shock of their life when you tell them that they have tuberculosis, because they always thought it's a disease restricted to a lower socioeconomic strata. So in the or we divide our tuberculosis into pre and post antibiotic era. So in the pre-antibiotic era, there was a stage of onset, a stage of destruction, stage of repair, and ankylosis. And how it was treated? It was treated in sanatoriums. I don't know about south, but north in the hill sites, we have a lot of sanatoriums which have historic importance. Then came an era of complete surgical extirpation, but that created a lot of mortality. And Callot once said, the surgeon who, so far as tuberculosis is concerned, swears to remove the evil from very root will find one result awaiting him, that is the death of his patient. So then, with the discovery of the antibiotics in from 1952 to present date, what was the we had become a surgical disease became a medical disease. What did it translate to? It translated into mortality decreasing to less than 1%, complete recovery going to 96%, duration coming down to around 18 months, and healing going up to 96%. So it's what is the pathophysiology? Slow going aerobic bacilli, primary focus in the lungs, lymph node, or genitourinary tract, mostly hematogenous dissemination. Bone and joint TB develops generally after 2-3 years of primary focus. So how it is hematogenous spread, bacilli reaches the paradiscal region, vertebral artery adjacent to the subendoplate. There's a ischemic necrosis. There's a bone loss due to hyperemia. Then develops a cold abscess, collapse, and deformity. Then causes of direct compression means granulation tissue, epidural abscess, sequestrum, instability, and healing stage it reaches into internal gibbous. So the last two stages lead into a neurological complications. The cold abscess is generally a tuberculosis granuloma tissue with caseous material and a necrotic bone. It accumulates under the anterior longitudinal ligament and graviates along the fascia and the neurovascular planes in the path of least resistant and can project externally. So there are around 5 types in the vertebral lesions: paradiscal, central, anterior, appendicular, or articular. Symptoms, basically, we have seen a mixed symptoms now. Tuberculosis can present like anything. These are typical symptoms which we have studied in our textbooks. This is a malaise, loss of appetite, night sweats, evening temperature. Then the specific symptoms features remain night cry, stiffness, deformity, restricted range, lymph node enlargement, abscess, and deficit. Paraplegia itself in a young disease is very, very rare. Spontaneous muscle twitching occurs, clumsiness walking. These are basically an upper motor symptoms you get. Motor is basically affected first as it's an anterior disease, and sensory and that is the tracts are affected the last. And severity, we looked at it stage 1, 2, 3, and 4, depending on the signs on the patient and his symptoms. They are negligible or severe. Uh, how do you approximate recovery of cord functions? It depends on the degree, duration, speed of onset, general condition, deformity, or cord changes. Depending on what all is present, the patient is either has a poor prognosis or has a better prognosis. So you can look at the prognosis studying all these factors. Paraplegics are two types, the early onset and the late onset. We already know. Early means appears between uh, 2 years of onset during active phase. Late onset appears after 2 years of disease. That is generally after the healing, and there is a canal stenosis, deformity, internal gibbous, which leads to a permanent neurological deficit and has a very poor prognosis. Investigations, you will have anemia, lymphocytosis, and differential count lymphocyte monocyte ratio is important. High lymphocyte mono and low monocyte count suggests good resistance. ESR is raised in active stage of the disease and normalizes over 3 months. Chest X-ray is very, very important, should be done in all the patients. Spine X-rays, Tankeshwar will talk about it. Radiologically, I just skipped through because Dr. Professor Tankesh will take a detailed on examination, imaging on tubular spine. So these are important. The abscesses, how they look out, the swellings that can give you a rough idea. The deformity, how the angles are calculated. MRI is an important tool. They said short of biopsy, MRI is the most accurate diagnostic investigation in tuberculosis. And what is important is 10% of what looks like TB is actually not TB. So it is another important thing is to get a whole spine X-ray to look for skip lesion. That's the norm now. And that is 100% true in cases of infection, tumors, and osteoporotic fractures that you screen the whole spine because there are always skip lesions present. Uh, these are, and then important is the differential diagnosis. So there are pyogenic, fungal, GCT, other benign lesions may mimic tuberculosis. So that is very, very important that you start your treatment based only on the biopsy. So differential diagnosis, I've listed it, I'll not speak on them. And there are some important presentation features which give us some idea how to differentiate between a pyogenic, tubercular brucellosis, or a metastatic disease. Because of the paucity of the time, I'll not go into each of them. As I've told you, biopsy is the investigation of choice, and this is how we do it. This is with a kyphoplastic kit. Only rule is that use a biopsy forceps, which is a cup shaped, so you don't crush the tissue. And I'll go skip the procedure. So important is to what samples should you send. It's always good to send a gene expert. Now you can have a second line gene expert also, which give you a test diagnosis in 2 hours. Then the culture for FTP, histopathology, staining, microscopic pyogenic culture, KOH mount, and a fungal culture. Thank you.
Uh, thank you, Dr. Rupinder, for such a wonderful presentation. I would invite the next speaker, Dr. Tankeshwar Barua, who is the professor and head at the Safdarjung Hospital. Over to you, Dr. Tankeshwar.
Thank you, Guru. And to clarify, I'm not head. Okay, I'm professor.
You are head of spine surgery. You
No,
are head
it's
for
okay.
us.
What we will. Okay. Now, I'm just trying to share my slides. Uh, okay. Is it visible, Guru?
Not as yet.
Now?
Not as
Now?
yet. We'll tell you when it is visible.
Okay. Okay, so I am just clicking my slides here.
Keshav, you have to start sharing, then open your presentation.
Okay.
Now open your presentation.
Is it?
Yes, yeah, just we can see that.
Okay, thank you. Am I audible?
Yes.
Okay, and the whole theme had been already spoken by Dr. Rupinder, so I'm not going to take too much time, but still for the formality. So, of course, that in TB, the high degree of suspicion is always important. Always think that TB is first. And as everyone knows that these are the investigation modalities, one should know about that: X-ray, CT, bone scan, magnetic MRI, PET scan, and also two for economic interest: diffuse weighted imaging and dynamic contrast enhanced MRI and computer aided diagnosis. May be helpful for the PG students for theoretical point of view. Now, access, as everyone knows, that it should have some amount of at least one third of bone loss to get some findings. So these are the findings that we can expect in X-ray whenever you get osteopenia with persistent back pain for long, or also with some kind of malaise or other symptoms, consonant symptoms. Always one should suspect tuberculosis. There might be some paradiscal haziness, end plate erosions, anterior vertebral body destruction, as essentially it is an anterior column disease, and sometimes we can get vertebra plana or collapse of vertebral body. Of course, in later stages we can get some kyphotic angulations or givas deformity. So these are some kinds of findings that we can expect in X-ray. Now, as Dr. Rupinder already said, that we might have, if you suspect tuberculosis or in any such, you can always ask for chest X-ray, which is very essential and it gives lots of clue. And sometimes in chest part of the X-ray or dorsal spine, you might see some barred nest appearance or some enlarged shadows in the paravertebral areas. And also there is one terminology known as shark tooth appearance. You can see like this. Usually this is the term where you can see new teeth in a children's mouth. Of course, MRI is the most sensitive and specific, as already have been spoken. In here, we can detect early changes, and we can. The most important finding is the marrow edema, paravertebral collection, and erosion, subligamentous spread of abscess, and there might be extensively bony destruction with preservation of disc space or height is usually pathognomy. Everyone knows tuberculosis bacilli, they need oxygen, and disc is a vascular structure, so usually they don't engulf discs at the starting. At the end, because of diffusion, discs may be damaged, and in some rare cases, as already has been said, cord compression or myelopathic changes might be there. Now in MRIs, one important one have to be very particular what kind of images they are seeing. It is T1, T2, star imaging, and sometimes contrast enhanced MRI also helps to find accurately diagnose tuberculosis. Now these two images, the one can see that in T1 images, usually we see hypointense of fluid part of edema, whatever it be. And in T2 images, one can see hyper intense like CSF, or one can see subcutaneous areas, one can see fatty changes. All these looks white, but the most importantly, everyone looks at whether star image is there or not. First, read the report, whether it is mentioned or not. If not, try to find out in the MRI. This is very important slide for most commonly for the postgraduate students and residents. They should know is how to see a star image. Now, designed to suppress fat signal, it suppress fat everywhere, highlight fluid and edema. How it looks, as in T2 image, we could see the subcutaneous layer was white. Here one can see that this subcutaneous layer become dark, that is fatty marrow become dark. All fatty marrow in vertebra become dark, but edematous marrow, inflammation, abscess fluid, they become bright. Like CSF also bright, but are not like T2 images. These are two images one can see. Look very carefully. One is T2 and one is star image. In star image, one can see this is looking more brighter than T2 in the pathological part. Now, sometimes what this is one patient who came to us with back pain only without any tubercular symptoms or something like that, but we suspected some kind of infection in the paradiscal area in L4, L5. Now, in this patient, we had suggested contrast MRI. See more clearly. Now you can see that fluid paradiscal edema, erosions, and in fact this also because of fluid is looking white, and eventually it's confirmed to be tuberculosis or tubercular spine. Resolution signs also very important. It's very important because at the end of course of treatment, like we used to give for 12 months. At the end, whether the TB is healed or not, at that particular time, we should always advise for an MRI. Of course, one can advise an MRI in between also if the disease is not healing. So at that time, one can see that all these prevertebral and epidural abscess had been subsided, and that beautifully this bone had been fused. So replacement of marrow with fat, resolution of edema and paravertebral abscess are important. Another patient which had been there is no abscess or something like that. Now ultrasonography is very useful specifically for collection of samples. Nowadays we can ask the radiologist to collect some sample under the guidance of ultrasound. No need to go for CT scan every time. In fact, in big abscess the radiologists they used to put pigtail application under ultrasonography. Now already had been spoken. Now this indication of CT, as you know, mainly important to see the bony destruction and planning of surgeries. These are one criteria for spinal risk signs. All radiology helps. I'm not going in detail. Yes, another one important point nowadays people emphasizing on PET scan. Why it is important? Sometimes in some selected cases we get very difficult to find out the initial lesions and also whether the TB had been healed or not. So in PET scan may help in some selected cases. This is one patient who had been treated before long time back with 18 months of ATT, but no healing up. We did a biopsy and came out to be drug resistant tuberculosis. We treated at that time, it was 24 months course. Still at the end of the treatment, patient as because of suspicion, patient is complaining lots of back pain. So we did PET scan, it was healed properly. Similarly, bone scan not so role, diffuse weighted imaging, computer aided imaging. Now left test as already had been spoken by Dr. Rupinder. But the most important point is biopsy. This is very controversial. In all places, it's not feasible. But whether we should go for biopsy in all patients or not? Yes, if possible and wherever feasible, we should advise or suggested biopsy in all of the patients because from medical legal point of view to rule out other diagnosis. But being endemic country in India, one can start TB on clinical radiological basis, no harm. So this is one patient presented initially with tuberculosis, but eventually came out to be aspergillosis. Similarly, this is one patient eventually came out to be spreading lymphoma. This is one case treated elsewhere and no response. We did everything, biopsy from bone, CT guided, open, no clue. But from the this sinus tract, it came out to be XDR-TB. All medicines were resistant and faring few. So biopsy is essential. One can go for CT guided, one can go for serum guided, but this is very important. Try to take as much as sample possible and try to send for all possible investigations like ZN staining, AB culture, CVNet, LPA whenever required or suspecting second drug resistance. Histopathology important, aerobic culture and fungal culture. This is CVNet. It's a very quick response. It gives report within 2 to 3 hours. Whenever doubt or in second line suspicions, one can advise for LPA. Nowadays, Government of India is in the robust technique CVNet or Gene Expert is available in most of the centers in Tier 2, Tier 3 cities or dot centers even. So the standard confirmation is culture. Nowadays, the culture is liquid culture or backtech or MGIT. It gives result within 6 weeks. DST is very essential. Other investigation, one may ask why Montox is important. Montox is not so important. One may be positive without TB also as it is already infested in a body. But Sometimes when we are in doubt, if we get with suspicion, get Monto positive, at least there is something that we can say that yes, I am going to start ATT. If patient is productive cough, go for the DST or sputum test. These are some differential diagnosis already had been mentioned, but one would be very particular that this fungal and brucellar spondylitis sometimes is very difficult to differentiate from tuberculosis. These are some mimickers. Looks like tuberculosis eventually came out to be pyogenic. Sometimes ankylosing spondylitis also behaves like tuberculosis. Paget's disease, yes. Degenerative spine sometimes very difficult to differentiate from tuberculosis like these patients. Paradiscal edematous changes. But if you get this type of findings, claw sign, usually these are not tuberculosis, lymphoma, as I had already mentioned, metastatic carcinoma, one example. I'm just going fast. Benign lung tumors, sometimes. So plasmacytoma sometimes confuse with tuberculosis. So in all these cases, we did biopsy. In fact, these later slides had been taken from Dr. Dharmendra of our Institute Radiology Department, musculoskeletal radiologist. CM, so CT guided biopsy or any biopsy is must for confirmation. And this is one guideline. Probably Dr. Rupinder had mentioned many things from this. I recommend all should go through this book also above index level guidelines. Lots of things have been explained in these guidelines. Government of India releases guidelines on and off. Without taking too much time, thank you once again. Thank you.
Thank you, Tankeshwar, and that was a great oversight into all the investigations. And we are now have a common thought process among all spine surgeons that tuberculosis should not be treated without a biopsy or a tissue diagnosis. Uh,
Thank
with
you.
this, I call our medical specialist. Dr. Atul Gogia is head of Department of Infectious Disease with us, and Dr. Anvita is an associate consultant in the infectious unit in Gangaram Hospital. I think Dr. Anvita will present medical management and drug-resistant tuberculosis, newer drugs, shorter regimes, and targeted delivery. And all of you can put in your questions in the chat, and at the end, Dr. Gogia, Anvita, or we'll take up the case. Dr. Anvita, please, or Atul, whoever was presenting.
Thank you, Dr. Rupinder, for having us here. It is indeed a pleasure to be speaking among topmost spine surgeons of the city and the country. And I'm sure in the next 15-20 minutes, Dr. Anvita would be deliberating about what is new and how to manage tuberculosis. We've had wonderful talks on how to approach and diagnose. And I think she would now go ahead with the presentation and tell us all. And if there are, I think there should be a lot of questions. And if there are questions, kindly let us know. We'll be more than happy in answering. Over to Dr. Anvita.
Good afternoon, good evening, everyone. Are my slides visible at the moment?
Yeah, visible, Dr. Anvita.
Yes. Sorry. Yeah, so good evening, everyone. Thank you so much for inviting us for this wonderful forum where we can discuss spinal tuberculosis management. First of all, as it has been reiterated, confirmation of tuberculosis is very, very mandatory before we initiate any patient on ETT. Even if we are prompted towards starting of empirical tuberculosis treatment, tissue diagnosis must be confirmed in an ideal setting and especially in a resource-rich setting. So much so, if we talk about in extrapulmonary tuberculosis patients, 50% can have sputum positivity. They would have a pulmonary finding. So even if we are not able to target the spine, we must try to target a sputum sample. And we have varied list of microbiological evidences that can be generated to help us guide into treatment and into drug resistance also, including, as what Dr. Rupinder mentioned, expert XDR. This is one of the most recent advances in tuberculosis management. It not just tells us rifampicin resistance, but it also talks about INH resistance, fluoroquinolone resistance, and aminoglycoside resistance. So it adds us and helps us in treatment management. Additionally, we must confirm the extent of the disease. So a scan like CT scan or a PET scan is recommended. We must attempt a microbiological confirmation either from sputum or any other lymph node which is visibly affected, or any collection. A weight charting at every follow-up visit is must so as to guide our weight-based treatment regime. Comorbidities like diabetes and HIV are a must to be evaluated at the first instant itself before starting ATT, because these comorbidities can really change the treatment paradigm. And a visual assessment at baseline is something which is often missed, and it is very, very critical. Ethambutol and linezolid are two major drugs which can cause optic neuritis. Hence, a baseline visual assessment can help us follow up these patients if in case need so for any side effects. This is a very comprehensive chart which I would request everyone to have in their phone or tablets, which talks about drug-sensitive tuberculosis, shorter regimes for MDR tuberculosis, all the weight bands, and even some monitoring and follow-up side effects which can be looked at. So to divide this, if we talk about drug-sensitive tuberculosis, our primary guidelines talk about 6 months of ATT, 2 months of HRZE, followed by 4 months of HRE. However, if we talk about extrapulmonary tuberculosis, these durations extend from 6 months to even 18 months, maximum being that of spinal tuberculosis, where 12 to 18 months is our duration where we have to follow up clinically, radiologically, and if possible, microbiologically to assess treatment completion. This shall be taken up further, so I will not be talking about how to decide on the duration, but as we can see, spinal tuberculosis tends to have the longest treatment duration, not just because of difficulty in management, but also because of difficulty in treatment and drug penetration to the targeted site. So, 2 months of HRZE intensive phase plus 10 months of continuation phase, extendable to 18 months on case-to-case basis. But most important key feature here is involvement of a multidisciplinary approach, where an orthopedic orthospine surgeon, internist, or an infectious disease specialist, along with a radiologist, and a vital role of physiotherapist and orthotist takes place. So a multidisciplinary approach is what can really help the patient. Now, coming to a few most commonly observed side effects. One is drug-induced liver injury. So on following up our patients, when we figure out that a patient has an ALT-AST rise of more than 5 times an upper limit, or a symptomatic patient with nausea, vomiting with 3 times the upper limit of transaminitis, this is characteristic of drug-induced liver injury. A bilirubin rise is often also noted as drug-induced liver injury. So simplest way of learning is Zehar. Z, H, and R. These three are the most hepatotoxic drugs of our first-line ATT, where Z being the most prominent, followed by H, and least is rifampicin. So Zehar is something that needs to be stopped immediately. We must start the patient immediately on modified ATT, which comprises of ethambutol, fluoroquinolone, linezolid, plus minus amikacin, and wait for the return of ALT levels to come to normal range. If we talk about how to reintroduce ATT, the guidelines of British Thoracic Society, WHO, and national guidelines have shown no difference. So we can either start consecutively, or we can start on half doses together, or we can serially reintroduce after every 3 to 4 days, completely depending on the compliance of the patients and the level of follow-up. So drug-induced liver injury is a very common side effect that we observe, and we must keep an eye on it, and we must counsel the patients to alert immediately and come to the doctor in case of any of these symptoms appear. Next most commonly observed side effect is hyperuricemia due to pyrazinamide. So hyperuricemia due to pyrazinamide should be an alarming feature, however, does not warrant stopping pyrazinamide unless patient is symptomatic. In asymptomatic patient having increased rise of uric acid, just simply add a febuxostat. A symptomatic patient, that is, a patient who's had a past history of gout or has a clearly acute attack of gout currently, we must give xanthine oxidase inhibitors, we must give a short course of NSAIDs or colchicine or raspberry and immediately discontinue pyrazinamide. Short of this, we can continue pyrazinamide with NSAIDs, we can continue pyrazinamide with febuxostat, and we must try to make sure that the patient is able to at least follow through the initiation phase of ATT, where pyrazinamide plays a very important role. Now, coming to drug-resistant tuberculosis, so we have INH monoresistant tuberculosis, where there is only resistance to INH. Then there is MDR tuberculosis, where there is INH and rifampicin resistance with or without other drugs. Pre-XDR TB, where there is MDR plus fluoroquinolone resistance, and XDR tuberculosis, where MDR, fluoroquinolone, and one group A drug is also resistant. India has a huge burden of all of these, and hence a microbiological diagnosis at the very onset of ATT management is mandatory. So if we come to MDR TB drugs, we have these group of drugs as group A, B, and C, where group A comprises of fluoroquinolone, bedaquiline, and linezolid. These formulate the basic backbone of MDR tuberculosis drug treatment. Group B drugs, which has clofazimine, cycloserine, or tedozolid. Then we have the further group C drugs. So in group A, we have to, these are the drugs which are highly efficacious. Group B are efficacious, but they have limited mortality benefits. And group C are lower priority drugs. So at least 4 core group drugs, that is 2 core drugs and 2 companion drugs, must comprise our TB treatment. So coming to the guidelines, according to the PMDT 2021, rifampicin resistance detected should be followed by further second-line DST, that is, second-line culture sensitivity testing. Basic attempt is to assess that whether we have fluoroquinolone resistance additionally and whether we have INH resistance additionally present or not. In case there is fluoroquinolone resistance, we have to go ahead with longer MDR TB treatment regime, that is the conventional regime, which I shall be talking about. However, if those exclusion criteria are met, then we can go for shorter all-oral bedaquiline regime. So what are these? So shorter oral bedaquiline based regime, or the MDR TB regime, is to be given only in patients who have INH resistance, who do not have any CADG mutation, and who do not have fluoroquinolone resistance. For these patients, we go for bedaquiline, levoflox, clofazimine. We go for basically a 6 months plus 5 months regime, which is bedaquiline based. However, children are excluded, previous exposure of fluoroquinolones is excluded, extensive tuberculosis is and severe extrapulmonary tuberculosis is excluded of this. Patients who fall into this exclusion criteria are recommended all oral longer regime, which is bedaquiline, levoflox or moxiflox, linezolid, clofazimine, and cycloserine. So this is the ultimate regime which is to be given and is currently recommended for patients who have spinal tuberculosis or bone tuberculosis. As the shorter bedaquiline-based regime is currently not recommended or not highly efficacious in patients who are having spinal tuberculosis due to drug penetration issues. Now, coming to the recent rapid communication by WHO. WHO recently launched that BPAL-M regime is the shortest bedaquiline-based regimen, which can last up to 6 months of duration. This was based on the recent TB practical and Xenix trials and the next trials. Let us go through it. So BPAL-M regime basically comprises of bedaquiline, pritomanid, linezolid, and moxiflox. This cocktail is given for 6 months, and this is found to be equally efficacious and non-inferior to the standard MDR long regimes. However, even though it has been approved by NDAP last year, it has been restricted usage in only extrapulmonary tuberculosis not of CNS, bone, or miliary origin, as there is lack of efficacy, lack of safety data in CNS, bone, and miliary tuberculosis. The drug penetration is uncertain, and hence bone tuberculosis currently is excluded in the guidelines when it comes to BPALM regime. So ultimately, we come back to our, we come back to the long all-oral regime for spinal tuberculosis, that is bedaquiline, levoflox, linezolid, clofazimine, and cycloserine. This is the current recommended regime. However, BPAL-M is currently under trial for spinal tuberculosis, and data is yet to come. Now, if we quickly go through the other MDR tuberculosis landmark trials, then we have NICS-TB trial, which formulates the basis of the BPAL-M regime, where XDR and MDR tuberculosis patients were given bedaquiline, pritomanid, and linezolid. However, one of the major side effects that this trial highlighted was linezolid-associated peripheral neuropathy in as high as 81% of the patients, and myelosuppression, that is thrombocytopenia and fallen TLC, in almost 50% of the patients. Because of, even though the efficacy and the non-inferiority was achieved, this drug was, this was warranted with high amounts of side effects. Then comes the TB practical trial, where all oral regime for rifampicin-resistant tuberculosis was tried with pritomanid along with moxiflox, which formulates the basis of BPAL-M regime, and this showed high efficacy, reduced side effects, and non-inferiority to the standard regime. ZNext trial was the next trial where different doses of linezolid were tried to prevent the side effects of thrombocytopenia, myelosuppression, and peripheral neuropathy. Here, the best dosing of linezolid that was concluded through the trial was 600 milligram once a day. So the linezolid dosing is recommended is 600 milligram once a day to begin with for the initial 4 to 6 months. And if linezolid needs to be extended beyond, then 300 milligrams can be continued to prevent long-term side effects. STAND-TB trial is another such trial where a combination of pyrazinamide was tried. Then BEAT India trial, which is currently ongoing in its part 2, tried bedaquiline with delamanid, linezolid, and clofazimine combination for pre-XDR tuberculosis with very promising results for 24 weeks. And this does not have any injectables or fluoroquinolones. The results are promising. However, the phase 2 is yet to come, and it's been rolled out in few states on compassionate basis. Simplicity trial is another one. Because of lack of time, I'll not be going through, but basically this trial tried long-term duration of pyrazinamide, and it led to severe hepatotoxic side effects. So pyrazinamide is one such drug which definitely leads to hepatotoxicity and should not be extended for more than 2 to 3 months of duration. Now, with so many failed and upcoming drug trials and combinations and so many newer combinations, newer technologies have also been tried to make sure that the drugs actually reach the target site. So nanocarrier ATT is one such new method where nanomedicine particles such as liposomes, nanoparticles, micelles, polymers, and nanosomes, these are tried, and this is the method of carrying ATT to the targeted site. They ensure targeted delivery, they reach the primary site of tuberculosis infection, and they reduce the systemic side effects and exposure. They have much better solubility and bioavailability. Sustained release have been tried over time, and they reduce drug-induced toxicities. Similarly, liposomal ATT has also been tried, which deliver the drug directly to the macrophages, which are the home to tuberculobacilli. They overcome the drug-resistant and they overcome the tuberculosis ATT-induced side effects and systemic toxicities. However, these are still under animal model trials, and they've not had efficacious human trials yet. But these definitely are promising results. So to conclude, the primary important step in starting tuberculosis treatment is microbiological confirmation at the onset. This is the key important step. The regime must be weight-based. The regime must be kept in mind based on the comorbidities and the presumed side effects that the patient is yet to have. monitoring and follow-up throughout the treatment is very important, as the duration of tuberculosis treatment for spinal TB is very long. MDR tuberculosis is a dreaded challenge because of its various drug regimes, because of sparse availability of drugs through NTP program in remote areas of the country, and most importantly, drug penetration to the bone is yet to be as efficacious as in pulmonary tuberculosis. Newer regimes have come up for MDR tuberculosis. They're very promising, but they're not yet confirmed for bone TB. They've not been approved yet. Newer technologies are coming up. They're very promising and exciting, and we're yet to see in the coming years how they fare. Thank you so much. I would really thank the organizers for giving me an opportunity to speak on this topic.
Thank you, Anvita. That was a great talk, and although we don't treat MDR, but it gives us insight at what all is now available, and special thanks to highlighting all the complications and prerequisites during starting of ATT. Most important one being the vision examination, which most of people don't do it. And I had spoken to our ophthalmologist. The blindness induced by combutol in the Indian population is irreversible. So actually, it is very, very important that we do it as a routine checkup. Thank you. The next talk was by Professor Niljan. He could not join, had some issues at personal level, went to stop tuberculosis. So I'll start with the case and then discuss it, but I'll take it at the end of the talk with the questions. And so the next talk will be by Dr. Ajay Shetty. Dr. Ajay Shetty is a president-elect for the Association of Spine Surgeons of India, and he's a senior spine surgeon at the world-famous Ganga Hospital, Coimbatore. And Ajay will be speaking on surgical decision making in 2025. That is the timing, technique, and technology.
Thank you, Rupinder. I hope you are able to see my slides.
Not yet, sir. Now we can see.
Okay, thank you. At the outset, my sincere thanks to Delhi Society and Rupinder and Guru Raj for this invite. You heard a lot about the current status of spinal tuberculosis, and I'm going to speak upon the surgical decision making in 2025, the timing, technique, and technology. There won't be anything major new in this, but I will currently bring about what people are practicing and what is going to change in the years to come. Uncompleted spinal tuberculosis is a medical disease. That is the absence of deformity, instability, and significant neurological deficit. And as you can see in this case example, a patient with a spinal tuberculosis with a huge abscess completely resolved with a good anti-tuberculous chemotherapy for a duration of 9 to 12 months duration. However, the presence of a complicated tuberculosis is a totally different entity. Coming to timing, what about surgery? We all know the classical indications for surgery: neurological deficit, severe vertebral infections, presence of spinal trace signs, and kyphotic deformity. What has changed from the time of this indication is that we always used to follow, decades ago, we used to follow Dr. Tuli's middle path regimen, wherein the patient is started on anti-tuberculous chemotherapy, and if he doesn't respond, then move over to a surgical management. However, with advances in technology and the safety of surgery being more, and also the anxiousness of the patient, we tend to operate with any patient with a neurological deficit, not waiting for them to respond to a chemotherapy. Other significant change that has happened is a necessity to operate on an elderly patient who is not able to ambulate without neurological deficit. Because the spinal tuberculosis in elderly differs from younger by having a higher comorbidity, and it's important that we tend to ambulate them early. Therefore, a stabilization along with an effective anti-tuberculous chemotherapy is essential to make these patients walk. What has changed also as regards to timing is the understanding of instability and the role of surgery in prevention of deformity. We all knew about the risk factors for severe progression: age less than 10 years, vertebral body loss, pre-treatment deformity of greater than 30 degrees, junctional lesions, and the presence of spinal trace signs. I mean, these have been classically been told over the last 2 to 3 decades that these are the risk factors for progression. Based on the SINS criteria, and this, as you can see in this particular case example, a child with the spinal trace signs still continued to treat conservatively and on to have a significant kyphotic deformity. Therefore, what is new is the understanding of instability in spinal tuberculosis and better definition of spinal tuberculosis. We know that instability in spinal tuberculosis differs in the pattern of spinal involvement, presence of simultaneous destruction and healing process, and unique pattern of neurological involvement as well as the deformity. Therefore, we now have instability scores, which basically are amalgamation of all the things what I have described so far. And you can divide a spine into a stable, potentially unstable, and a defined instability when the score is greater than 3. As you can see, it's basically younger age group, junctional tuberculosis, greater than 30 degrees of kyphosis, vertebral blood loss, vertebral body loss of greater than 0.5, spine at rest signs, and these are the things. Similarly, there are 2 instability scores, one coming from our institute, other from Pankaj from northern part of India, but basically most of them, they also follow the same lines as the SINS, as the spinal instability neoplastic score. They follow the same lines. But however, as you can see in this case example, even though the instability score-wise is only 2, you may have to stabilize this patient in a lumbar spine because in an idea not to allow progression of deformity and loss of lumbar lordosis. Therefore, all this instability score gives us a guideline, but whenever there is a potentially unstable, we need to take other factors into consideration and the individual surgeon's judgment before we plan surgical management. Coming to technique, what has changed, which surgery to do? The goals of surgical treatment still remains the same: decompression, deformity correction, and stability. I mean, depending upon what the patient has had, we need to address these 3 things that the patient has to have at the end of the treatment. We all know the popular Hong Kong surgery, which paved way for the advance in the overall in the anterior surgery for spine, still remains the gold standard for cervical tuberculosis. However, in thoracic and thoracolumbar tuberculosis, the pendulum has swung and posterior fusion is now preferred. However, the pendulum is swinging again now with the advances in MIS techniques. Therefore, more and more surgeons, especially in the developed world, are doing anterior procedures again, either by MIS or by endoscopy, and do percutaneous fixation by posterior means. And also what we have realized now is the fact that debridement is not very essential in most of these case scenarios, especially in patient who doesn't have significant bony compression of the thecal sac. As you can see in this case examples, even if there is a mild or a moderate debridement or a no debridement, if there is a cold abscess, they tend to resolve with stabilization and medical management. Therefore, in patients with multi-segment or posi-segment, in patients with posi-segment disease, that means involvement of only 2 adjacent vertebra, a posterior only surgery could be adequate when the vertebral blood loss is less than 1 and whenever there is a multi-level involvement. Even if there is a significant defect in the front, what you can see as what we have done in this particular case, you do a laminectomy, remove part of the pedicle and do a gentle compression. As you can see here, because the lesion is soft, it is flexible, you can achieve an adequate amount of correction without a need to an aggressive debridement, aggressive reconstruction, which makes the overall surgery much more complicated. We looked into this into 2 separate studies. One is a prospective randomized study wherein we looked at patients between 0.5 to 0.5 to 1 vertebral loss. One group had only posterior stabilization, another group had an anterior reconstruction, as you can see in the figure. But what we found was there is no major difference in clinical, functional, and radiological outcome between these two groups, provided they had a very good medical management. We also looked at other aspect between three groups. Group A with cage reconstruction, Group B with anterior autologous bone graft, and Group C with the posterior column shortening. Without anterior reconstruction, as you can see, these are the case example. We reconstructed, we just put bone graft, or we just stabilized. But in the end, there was no major difference. But however, a better correction of the deformity happened in patients with anterior cage reconstruction, even though it was not very, very significant. Therefore, what does it mean to say that stability is the most important thing? Number two, a good antituberculous chemotherapy is very important. And if the defect is only very, very large, then only you need to reconstruct and debride very less. Again, what has changed regarding the instrumentation is the fact that we tend to use a lot of index screw or screw through the infected vertebral body so that to decrease the length of instrumentation. That is the only new thing that has changed with regards to instrumentation. Therefore, what has changed in the third important question? What has changed in the surgical technique? What is new is minimally invasive technique, technology-enhanced planning, that means use of navigation and robotics, 3D printing, and innovations in bone grafting. We know that MIS techniques are minimally invasive, less morbid, direct visualization. It helps debridement and drainage, addresses instability by percutaneous screw fixation, reduced recovery time, reduced complication, and improved clinical outcome. If you look at the literature, as you can see in the PubMed base here, in the last 5 years, there is a significant increase of publications with related to endoscopy in spinal tuberculosis, as seen by some of these publications. It could mean uniportal or biportal endoscopic debridement with percutaneous stabilization. It could mean thoracoscopic procedures or mini open procedures. As you can see, the scars are very, very smaller. And these are going to become the norm with the years to come. As I mentioned, there are significant benefits with regards to MIS techniques, which we are all aware of. Again, a study from Pankaj's team from AIIMS Rishikesh. They looked at the difference in outcome between open and MIS techniques, and they found MIS techniques has got a lower blood loss and better early VAS scores. But however, open surgery is superior in kyphotic correction. Therefore, what does it mean? In patients who do not have significant deformity, MIS technique still remains the better option. But however, patients who have got deformity, especially in thoracic area, open techniques are probably preferable. Therefore, there are various options, as I mentioned. It could be used for percutaneous drainage, video-assisted surgery, MIS techniques, OLIF, ALIFs, and endoscopic techniques. And they are probably the future with the years to come. What about robotics and navigation? There has not been a significant increase because tuberculosis affects basically poorer patients. And all this newer technology like robotics and navigation comes with the increased cost. And the help it provides is basically enhanced screw accuracy. Either you use robotics, navigation, 3D printed implants, 3D printed guides. They all only help in enhanced screw placement accuracy. Safety decreases the surgical time, but overall it increases the cost. But most of these patients with spinal tuberculosis are very poor patients. And if you see the chart with Rupinder showed, they are basically coming from countries which are socioeconomically backward. And therefore, the use of this technology may not be very, very practicable till the years to come. Coming to bone grafts, autologous and the titanium mesh gauge still remains the gold standard. The allogenic grafts are not commonly used, and ceramics were probably years to come. One of the disadvantages of newer techniques like 3D printed implants, navigation, robotics have always been the cost. And that has been, any new technology comes with a significant increase in the healthcare cost. And that's what we have to keep in mind and to weigh against the benefit to the patient and the cost to the society overall. To conclude, uncomplicated spinal tuberculosis still can be treated medically, but in some group of patients who have got kyphosis, neurological deficit, and instability, surgery could be indicated. As of today, posterior-only surgery is adequate for cervical, for the thoracic and the lumbar area. All posterior approach provides better short outcome. What we have understood now is to debride less, use MIS techniques whenever that is possible so that you allow the individual to rehabilitate faster. Navigation robotics could be beneficial, but it's only for screw placement and probably sometimes to guide you through the entry areas or to localize the lesion, but still very expensive. Thank you again, and thanks Rupinder for the invite for this session.
Thank you. Thank you, sir, Ajay sir. And that was actually, it's making us aware of where do we stand in terms of spinal TB today. After we know that where do we stand, now I would like to invite Dr. Sunil Katoch, senior spine surgeon from Max Hospital, Delhi, to take us through the complications of spinal TB and follow-up and rehabilitation. Over to you, Dr. Sunil Katoch. Unfortunately, Dr. Bajaj couldn't be there with us today because of his suffering from viral fever. So Dr. Katoch, at the last moment, readily agreed to take this topic. Thank you very much. So we can see your slide. Can we make it full screen? So slideshow down there. Katoch sir, you are muted also.
Now?
Yes, sir, I can hear you, and it's not on the slideshow mode, sir. So please share the entire screen and then do it. That's better. Just unshare, sir. Unshare.
Or you press on that glass thing down.
Is that what?
Sir, down there is one icon near the zoom in bar is there. Comments, notes, comments. And then at the end, you can see that one screen option is there. We have to press that.
No, I can't see that.
On the
Layouts.
right hand side corner of the screen, sir. So you can see there are one book like thing is there. Beside that, we have to press that.
No, I can't.
Right lower corner, sir. Right lower corner.
Right lower corner.
Right lower corner.
Where there is a percentage written, na? The left to that, the first
icon.
Four icons.
First icon from the right side. No, we can't see your cursor either, sir.
Slides. So I will stop share first.
And share your entire screen first. When you press on the share button, you will see whether to share the presentation or entire screen. You share entire screen first. Screen, yes.
Now?
And share. After you press the screen, you press the share.
Now is that okay?
Now come to that lower corner, right hand side lower corner.
Yes,
down, sir. Still down. Yes. That. Yeah. No. Next to this.
Left side. Yes.
Click on that. Yes.
Now is it okay?
Done.
So good evening, friends, and thank you, Dr. Rupinder and Dr. Guru. I regret Dr. Bajaj, he's unwell. The topic of the complications too really vast to be discussed in the time available, but we'll try and cover in the major points, and happy to take up questions in the end. The complications of spinal TB, most serious complications of spinal TB remain neurological deficit, wherein para and tetraplegia with loss of bowel and bladder control, due to direct or indirect compression of the neural structures. Paralysis leads to many problems. Early onset paraplegia up to 6 months to 2 years due to inflammatory edema, abscess already discussed, and probably likely reversible with diet, rest, and anti-tubercular medicines. But this is the stage which is very difficult for patient and their family to go through. I mean, waiting for something to happen while we are all watching. So many a times people panic, doctors, I mean surgeons, and as well as the family of the patient, they panic, and we land into surgical treatment. And this is a very difficult time. But in late onset paraplegia, which takes months and years to come in, it's a hard compression on neural structures leading to almost permanent paralysis. And treatment and correction of this is requiring major surgery and very intensive post-op care and rehabilitation. And risk factors for developing neurological deficit will be a dorsal spine because of canal cord ratio. Multiple vertebrae involvement leads to really severe kyphosis more than 100 degrees, inadequate ATT, drug resistance, poor nutrition. And nowadays we see, even post-transplant surgeries as these numbers have increased. In our institution alone, they are doing more than 30 to 60 transplant surgeries every month. And they are on immunosuppressants and, of course, the age. And the poor understanding of the serious nature of tuberculosis. And we have to take the TB infection really seriously and carry on. Then the complications of neurological deficit are urinary or fecal incontinence, decubitus ulcers, recurrent urinary infection, sepsis, pulmonary embolism, poor general condition. Psychologically, it is devastating. And clear message is to really prevent a neurological deficit, because TB is a systemic disease and not a local issue. Improve general condition, nutrition, give them rest, monitor liver function, involve a physician. And if patient is fit, definitely do a surgery if indicated. Stabilize spine, decompress, ideal. But there are many caveats about this statement, as Dr. Ajay has just stated. And warn about prognosis. The cord at risk is really very angry, and little bit of handling can lead to a neurological deficit which may or may not recover. And cases like these, if continue to ambulate, we are looking at a disaster ahead. And in these soft cases, if we give them adequate rest, I'm sure they can heal. And surgery in these patients with severe deformities, restrictive lung function, compression of the cord, myelomalacia, arachnoiditis, and severe canal stenosis, adjacent segment degenerative disease, facetal hypertrophy, and patient has mechanical pain. And there is a lot of other systems which get involved. And even if we treat them and we don't correct them, it's really of no great use. And paralysis of TB spine, as we just mentioned, that it could be early, it's reversible, and late, it's very hard to reverse. And a very careful assessment and advice that we have been instituting for a very long time is nutrition. We really spend some time in advising them nutrition and rest, which is so important. And in complications, in neurology, there is neurological deficit. For orthopods, it's a deformity. Infection, it's a difficult disease to heal. And if there is systemic effects, as TB spine is part of a miliary process, so there is systemic dissemination, consumption. The patient's energy is really gone. And treatment has its own potential drug toxicity to liver and other organs. And in one patient, in so many years, we've had opportunity to screen. Almost all systems were involved. And you could see tuberculosis from really neck downwards, skip lesions, liver involvement, lung involvement, even scrotal skin was involved. Tubercular cold abscess, they lack signs of inflammation. It's a painless cyst, may track along muscles like psoas and others, including thoracic spine when it tracks down. And they can press on vital structures like airways and esophagus, like in this case. And it could be very, very severe. Kyphosis due to spinal tuberculosis, we don't worry so much about in active disease as it is correctable. Medical treatment has to be reinstituted, rest with bracing, anterior or posterior debridement and fusion. Firstly, don't let the kyphosis happen, but advise surgery early, because each degree that the kyphosis increases, it becomes difficult for the surgery and more risky for patient. And of course, as it progresses, it affects cosmetic look. Always shorten the spine, closing wedge osteotomy like has just been told. Then management of neurological deficit. We profess rest in bed till pain of turning settles, too early turning with exercises as regimentalization, in bed exercises for chest, upper and lower limbs, prevent complications of now paraplegia or tetraplegia like DVT, pneumonia, pressure sores, urinary infections, urinary stones, joint contractures, wasting of the remaining muscle power, and keep up the morale of the patient and the family, and involve a social worker. In-bed tasks to the patient can be given to keep them amused while the treatment heals them. When does one judge healing? That is combination of clinical judgment guided by lab and the MRI scans. We do take a scan at about 6 months to understand whether things are working for patient or not. But there are clinical signs of healing, return of appetite, weight gain. Patient really starts feeling well, relief of pain initially in turning and then in loading. Neurological recovery starts happening. And on a scanning, we can see, or even if it was the abscess was palpable, then resolution starts happening. And on MRI or investigation, we can see the bright marrow signals becomes isointense. On T1, hypointense marrows regains intermediate signal. Bony fusion starts occurring. You can see normal bony architecture replacing initially the fatty and then the normal bony. Collections disappear and no new lesions are occurring. And my take-home message will be, it's better to prevent complications of spinal TB, especially kyphosis, as it is life of misery, low esteem, depression, and ultimately a sad end. The spine must heal in normal alignment as far as possible. Bed rest, nutrition, and quality medicine are three cornerstones sharing the load of ATT and not pharmacotherapy alone. Thank you very much.
Thank you, sir. And thank you. It was an excellent talk, although we did let you and informed you early morning itself. And so you have done a great justice to it. And that is your past experience in handling all the rehabilitation at spinal injury center, that these things are at back of your hand. Next is the Dr. Jain's topic, I think. Guru, that's the last, I think.
Yeah, that's the last talk. Actually, we shifted it as the last talk because Dr. Anil Jain also couldn't attend. But then we have just modified the talk. Dr. Rupinder will present a case, and based upon that, we will all discuss. Really, Dr. Ajay sir and Dr. Sunil, We will need your inputs. Really, when to actually, this is the crux of the topic: when to stop the anti-tubercular treatment in spinal tuberculosis. Over to you, Dr. Upinder. You can
Yes.
start with your
So,
case, and then we
so
can take
I
up.
have just have a case, and I'll give you my opinion how I do it, and then probably share this some questions with all of you. I'll just take few minutes. This is just morning. I collected some slides. So this was the case of 34-year-old man with neck pain, neurologically intact on ATT for 2 months, and then these are that 1 year. So I get the MRI done, and all the labs and everything are regularly done. But the MRI at 1 year, unless until there is some issue in the or there is a slowdown of progression or a newer symptoms come up. So at 1 year, you can see a good healing, stable spine, and but then this abscess is there. Inflammatory markers are normal, and now the question is, should you stop ATT or continue? This is 1 year.
Okay, can we, Rupinder, can we take the question?
Yeah.
Ajay, sir?
Yeah, if it's just an abscess, if there are no inflammatory markers, I wouldn't be worried. I mean, as been now, there are a lot of papers also published from CMC Vellore saying that the presence of an abscess when the bony changes are completely healed doesn't imply that we need to continue antituberculous drugs. Dr. Anil Jain is not here. Other option is to get a PET scan to see if there is any active intake of increased uptake of PET scan. If the PET scan shows increased uptake, then it's a different ballgame. But usually these cold abscesses with no bony changes, there won't be any increased uptake. My choice, look at the inflammatory parameters, the clinical response, patient is and overall looks good. Only presence of a cold abscess, I wouldn't be worried too much.
Okay.
Could this be insisted? Or, could this abscess be insisted and its ATT is not able to work there?
Sir, we have also seen in our practice that if there is still abscess, it just slowly gets absorbed even if you stop ATT. It's not because ATT is not able to enter into the abscess and it is not decreasing, because anyhow the pus or the soft tissue shadow which we see there, it doesn't have any blood supply because it doesn't enhance in the contrast CT and MRIs. So anyhow, the ATT doesn't reach these areas. So
So
it really doesn't matter.
any role if this is an accessible area, would you aspirate it then investigate it? Because the gene expert will anyway, even if it's a dead mycobacteria, will come up as a positive. So the only role will remain of a culture. I think we can ask a medical specialist what is their opinion on this culture of abscess at 1 year. Atul, Anvita.
Yeah, that's a very pertinent question and a very difficult question actually to answer. And when to stop is always a challenge, whether it is any extra pulmonary TB, it becomes a big challenge, spinal TB more so. So, as you said, gene expert would be positive. So, we have to carry home this message that gene expert will be positive. So, we don't have to chase that. You can do direct fluorescence, AFB smear, which can, tell you to some extent as to whether we are still dealing with microbiological TB. Because if it is still there, then you can think of an MDR kind of a thing. But all the time, it's not possible for us to, aspirate, or it's not accessible, and it's difficult. So it's a difficult scenario. If Dr. Anmita is around, if she wants to add something there.
Okay, Dr. Anmita is not. Dr. Katochi wanted to add something.
Yeah, in a number of cases that we have had, we've aspirated them, and we've got positive positive cultures, and we've continued ATT for a while till when these really disappeared. I mean, that is our experience. I need maybe more cases to answer that so confidently, but many times the bacterial cultures sensitivity changes over a period of time.
Yeah, that is a very right point. Sorry to intervene. That is a very pertinent point. There is something called heteroresistance, which can, develop in these patients. So you may have some patients who are susceptible, some who are becoming resistant. So that is another challenge. But yeah, the take-home message I think is that we should try to attempt it and look for a direct fluorescence and do a culture wherever possible.
Okay, so I have a question and I have a comment. Basically, if in case of spinal tuberculosis, if you're like Dr. Ajay mentioned, your bone is healing, you see that the bony edema has disappeared and it shows fatty replacement. It's fusing. Clinically, patient has got better. Weight gain is there. Where loss of appetite has disappeared. Patient is really feeling well, no pain. Still, you aspirate because in all these scenarios, I feel aspiration might cause more complications rather than help. Dr. Katoch and Dr. Atul.
Guru.
Yes, sir. Yeah, Tankeshwar.
Okay, so what we are following, as you had rightly said now, patient is symptom free, gaining weight, no symptoms, and also radiologically complete, no signs of inflammation. We stopped at 12, full stop. But in some selected cases, all parameters are okay, but abscess is there, still some having symptoms. In those gray zone cases, we continue for another 6 months as 12 to 18 months the regime. But when the patient is no improvement, pain is persistent, weight is not gaining, some kind of symptoms, then only we encourage them for some kind of intervention. That means for biopsy or culture for microbiological confirmation to rule out drug-resistant tuberculosis. What we are following here.
No, that is true, Tankeshwar. Here the question is patient is all well, everything is healed, everything is seen, you see this abscess.
I am not going to continue ATT. I will stop here.
Sure.
So Ajay sir,
Yeah.
in your experience, like what actually makes you continue ATT more than 1 year? And like in last maybe 5 years, how many times you have continued more than 1 year?
What makes me continue is a patient who has not clinically done well, who has not put off weight, that is the main thing. What I do is usually I get ESR, LFT, and check their weight at every visit and see how is their well-being. That's number one. And in those patients whose there is radiologically not healing, I get a MRI scan done. I try to do MRI for everybody. It may not be possible, but in 80% of my patients, I get an MRI done at around 8 to 9 months to know how it is healing, but I tend to continue for 1 year as per the government recommendations. If the MRI does not show evidence of bony healing, that means the conversion into a fat marrow, that means that's the situation. I will take an opinion of either an infectious disease specialist or a pulmonologist who does treat tuberculosis. And based on their recommendation, maybe I would have probably around 4 to 5 patients, if I remember right, that I need to continue the anti-tuberculous drugs maybe for another 4 to 6 months more. When there is a partial response, but completely no response, definitely I would think in terms of a drug-resistant TB.
That's true. Okay, Rupinder, you have.
Yeah, that is what I follow also. It's if there is a bony edema or anything, this is an isolated abscess, you can ignore it. But if there are intraosseous changes, probably I would continue beyond that. But I do MRI at every patient for at 1 year.
Ajay sir,
Only
your
one
hand is
point
raised.
I would like to highlight is the fact that since it's a part of a national tuberculosis program, do not hesitate to get an opinion of a specialist. I mean, whenever there is a doubt, I mean, it becomes mandatory that when there is a doubt with regards to drug, whether the patient has got altered liver function, anything for that matter, we should not, and drug-resistant tuberculosis, we should not try to treat it on our own and get the involvement of specialists in that field which are recognized by the government.
So why is there confusion in this? Confusion is because the healed status, that is the endpoint of treatment in tuberculosis spine, is not defined. Hence, optimal duration is still unresolved. And all recommendations basically earlier were based on extrapolation of guidelines used for duration of chemotherapy for pulmonary or other forms of tuberculosis. So there is no definite defined endpoint of health status, whether it's clinical, radiological, or parametrical. So what is the way out? Way out is resampling, which is not possible at most of the cases in spinal tuberculosis. So we need is a reliable, reproducible, and validated test, which we don't have as of now. And in literature also, people have tried different regimes, and you have this one with the 6 versus 12 months also. People have tried 6 months also, where they had 68 patients randomized, 100 patients randomized into 6 month ATT and 12 months ATT. So they looked at all these features. So what was the drawback with this was that this had a level 2 evidence, single center ATT regime given was different from the anti RNTCP, and all the patients did not have a microbiological diagnosis. Clinical improvement was taken as the patient is feeling better, which every patient does after 2 months of ATT. Inflammatory markers, most of them come down. Radiology, remineralization of vertebral body, sharpening of disc margin, reduction of shadows, osteofibration, signs of healing X-ray, but are unreliable. Significant regression in epidural or paraspinal abscess, granular tissue, marrow conversion, reconversion, and fat reconstitution of the diseased bone at final follow-up was called up as healing. So this is what we've seen. So as what I normally practice is you look at the clinic lab results, which most of them do come down. X-rays is good to look at fusion. It's also look at the disease activity. So SUV value 0 is a confirmatory. There is no that the lesion is completely healed. So it is. I personally feel it is unscientific to stop ATT by fixed time frame. Treatment should be extended till the healing of lesion is not demonstrated clinically, lab reports, and radiologically, and which may at times extend beyond 1 year. Uh, PET CT, I think a lot of people have. We did a thesis. One of our students did a thesis on PET CT, but problem is, I think, the cost effectiveness, and it is important to have a baseline PET also. If you have to stop ATT just based on the PET CT. Atul, what is your view on that?
So I feel if you're talking about when in doubt, so these will be very selected patients. So as everybody said, all the experts, the spine people feel that, when the clinically patient is doing fine, you do an MR and all the inflammatory markers and everything is fine, then you don't have to worry. So it is those selected few patients which may have residual disease and you are not sure whether it is an active disease or it is just fibrosis or healing or things like that. In those cases, or patients who are immunocompromised, you don't want to take a chance. A PET CT, current days and time, cost is not a matter actually. I think the PET CT is in a lot of labs are doing it very cheaply. So you can, in 10,000-15,000 rupees also you can do a PET CT, which is, comparable to some of the MR scans also. So I think doing a PET CT will give you the kind of inflammation. If there is no inflammation, no active uptake, SUV max is not there, then you can be quite confident in these days of medical legal thing also. You can actually document that there is no lesion which is, lighting up. So you can be fairly confident unless and until patient is symptomatic. And rightly so, if patient is symptomatic, then you either put in a needle or you continue the ATT and see for resolution in 3 to 6 months, depending on patient's condition. I think that is the way forward, and that's the way we think. Because a lot of times, recently there is a patient, he's planned for kidney transplant. So there are nodes which have resolved. you are not sure whether the residual, how long to give. You want to do a kidney transplant, patient is waiting, donor is waiting. So PET scan will show you, that kind of a setting. So PET scan definitely adds value there.
Anyone doing a technetium bone scan for this?
I think PET is like an updated version of a technetium bone scan. But my question is the fact that at 6 months or 7 months, the MRI shows resolution of an abscess and the disease healing. Are we justifiable to stop the drugs? Because the RNTCP says that you have to take it for 1 year. Number one. Number two, with the use of ethambutol now as a part of a continuation phase, we are seeing more and more people with ophthalmic issues. Because when we used to stop ethambutol at 2 months, usually we never used to have an issue. But when they continue for 8 months, 9 months, 1 year, they tend to develop optic neuritis is much more than what we used to see earlier. Therefore, these two are the issues which I see in my practice. Sometimes you get an MRI at 8 months, it is completely healed. Shall I stop the drug or is it necessary for me to continue that 1 year course? Either Dr. Anvita or Dr. Atul.
So I think we have to complete the course. There is no doubt. There is resolution, there is improvement, that's fine. But we have to definitely complete the course. Coming to the second point, ethambutol toxicity, definitely that is a major concern. So that is something one of our students has also done a thesis on the neuritis because of ethambutol. So we never used to think rightly as when we were giving it only for 2 months as the initial phase. But now with the continuation phase, continuing the drug is a problem. But then you have to counsel your patient that ethambutol is a drug which can cause a problem. And you need to do every 2 to 3 months, you have to do an ophthalmologic examination, and you have to be aware the way you're doing LFT every 1 or 2 months. So eye checkup is also part of the protocol. So all our patients, I'm telling them and writing them on the paper to get an eye checkup done to rule out ethambutol toxicity. Because people think eye checkup hai, they would just go to an optometrist, get an eye checkup. That is not has to be done. So you have to counsel them. So it is very important that we document and counsel them that this is a side effect which is there and we need to see it. So every 2 to 3 months, depending on. And the other thing is patients who are already having blindness, issues with, who are, patients who are quadriplegic, not stroke patients who are not able to tell you whether vision is a problem. We avoid ethambutol in that set of patients.
Okay.
So that is another thing, because a lot of CNS, because CNS TB, ethambutol has a very poor penetration, CNS. So it is not a good drug for CNS. So we just do away with it, especially stroke patients, patients who are not able to speak, not able to tell, elderly patients who are not able to tell us कि भाई vision में कुछ problem है, or they may not go regularly to an ophthalmologist. There you can avoid, ethambutol maybe after initial time and add on another drug depending on the tolerability or the other factors.
Okay.
Okay.
One thing
Thank you.
I wanted to know is that you do eye examination from 0 to 2 months or after 4 months, 6 months or?
So normally 2 to 3 months is what I recommend to all my patients, and that is what the protocol is. Every 3 months, at least every 3 months or 2 to 3 months. So when continuation phase is over, I start telling them, please get, because they may take up to a month to get it done also.
Yes.
We could not go, we did not follow up, doctor, this happened, that happened. So from 2 months onward, I start telling them. So generally every 3 months, definitely we do the test. So even now that we are giving 6 months also, I would tell at least 2 eye examination done during that time. 3
I
months.
advise every 6 weeks. But by the time they come back, it is 2 months. But on paper, I always advise 6 weeks because
so it's important that we clearly mention on the paper that this is there.
Okay. Thank you.
Thank you, sir. I'm having a question. Can I ask? Time allows.
Yes.
Yeah. Last question, and then we have some questions in the chat box, and then we'll.
Okay, fine. One thing, before we used to do lots of DST, drug sensitivity test. But because of this new regime, all oral longer regime, whatever with bedaquiline containing, should we recommend patients for costlier DSTs for second line drugs or not? Because whatever the DST we get, the end result is the same all oral regimen, including bedaquiline and whatever is there. So should we ask for DSTs or only culture?
Dr. Atul, or
Ask for everything.
Sorry, No, sorry, I didn't understand the whole question. You want to say that we should do DST in all or not?
yes, yes, that was the question, Dr. Atul.
Neil, what we do in our hospital is we do the culture only. We don't do culture and sensitivity because then they charge for the sensitivity also.
No,
So
that's everywhere.
Ah.
You do the culture. If it comes positivity, then you send for the
Test
first line, second line.
first 4 lines, first 4 drugs. Rifampicin already know if others are also there. Otherwise, if MTR, then I test all 10.
So if you're sending a gene expert, now the gene expert is a standard for everyone. So if you are getting a gene expert done and you are getting a rifampicin sensitive report, then you presume that these patients are non-MDR. So you are sending in a culture report. Generally, as Dr. Rupinder says, that we are doing it for patients without sensitivity upfront because 50% or more times you may not grow any organism, so you don't waste the charge for sensitivity. But once they grow anything after 2, 4, 6 weeks, whenever the report is, generally I would tell them to do a 5-drug sensitivity, which they do upfront. If that is sensitive, then we don't do anything. If that shows resistance, then you can do the 10-drug panel for other, because the cost is a factor. The other thing is, why, if you will say, when gene expert is saying rifampicin sensitive, what is the point of doing the 5-drug also first line? Because around 8 to 10% is INH monoresistance. There is something called INH monoresistance to the tune of 10% to 12%. So if INH resistance is picked up on the culture, then probably you need to modify your therapy, because that is why it is the countries like India where the INH monoresistance is high. That is why the continuation phase is now saying to take ethambutol, because that reduces the or covers the monoresistance because of the INH. So that is why that is the importance there.
Thank you.
Okay, thank you, sir. So we have 2-3 questions on the chat box. First question is again, Dr. Atul. Sorry, we are troubling you more.
No problem.
So is there a DOTS regime is sufficient for like spinal tuberculosis or osteoarticular tuberculosis?
So basically, we have to follow the national guidelines, but the guidelines are also very open. If you read the guidelines, they say you have to see the clinico-radiological condition also. So it is not that you have to stop at 1 year, or you can give longer, or you can tailor the drug depending on the toxicity and tolerability. So there is a leverage to that, but obviously you have to be using prudent clinical sense. You just don't keep on giving a drug when it is not required, or when it is causing a toxicity, patient is becoming blind. Linezolid is one of the most abused drug, I'm sorry to say, by most of the orthopedician colleagues and all. It is used so much. So linezolid is a drug which causes a lot of myelosuppression. I get to see patient when their hemoglobin comes to 6 and the TLC is 2000. Now that is the time it is referred. That's to see now platelets are less. So linezolid is also causes optic neuritis. It also causes peripheral neuropathy. It also causes serotonin syndrome when you are giving it for long time. So it is important that whatever drug we are giving, we choose them appropriately. So there is not a problem. You can tailor your treatment, but 1 year obviously you have to give the spinal.
What if the question was, do you DOTS? DOTS, is their DOTS valid now?
DOTS, no. DOTS, basically, there is nothing. DOTS was directly observed therapy system. So that is not something which is mandatory. It is just that you have to ensure that the compliance is there. That's all.
Sir, but then a lot of our patients, when they visit the TB hospitals or a dispensary for treatment for drugs, they give the same dots medicines for a extrapulmonary tuberculosis also, and
Guru, can I?
they say
No, the medicine remains the same. It is just they want you to ensure that the TB treatment is being taken properly. You have to give empty bottles or strips to them so as to ensure the compliance.
Guru, can I take the answer?
yeah, yeah.
Okay, so as I am working in a public hospital, and for last 5 to 7 years, maybe, and 5 to 10 years, we are constantly using DOTS regime with not DOTS exactly, we constantly using the regimes from NTEP without any default, without any problem. Whenever there is drug resistance TB, we send to this manually center, and they also manage very nicely. So probably our patients are like this; they takes, and we are not getting any problem since then.
Basically, you mean to say the kit is fine. There is not a problem. It is dose weight, and it is the kit which is being given. That is not a problem. You can
Yeah,
take that
the
kit. There is
adherence
no
to the
problem.
regime is important. Yes.
It is they have the weight bands which is available online anywhere. You can see for yourself, and the medicine is pre-mixed as per the weight band, and that is what it is given at the TB centers, whether it is the Meroli or any of the TB centers, because it's a national program. So
Yes, sir.
you can follow
Yes.
that.
Sir, Kato sir.
No, just I wanted to make 2 points. One, that our patients with spine TB are advised rest in bed. So their mobility to go and go to the centers, take medicines, and be directly observed is in question. Second is that a dictum was there that you can spit into the abdomen, but you cannot breathe on bone. So bones are, once they are infected, things are very, very difficult.
So Katusa, I am getting no problem, and they had a designated attendant who had been advised to collect medicines. Nowadays,
Yeah,
no need to go by the patient themselves.
Okay,
yeah.
I didn't know that.
They help these days. They are helpful.
Okay.
They may even we have patients who are admitted in the hospital, and we have to use bedaquiline, delamanide, these kind of things. So then what we have a counselor who coordinates with the nearest TB center.
Okay.
We give them the reports.
Okay.
They cross-check the reports, and then they give bedaquiline, because bedaquiline is not available in the open market. It's available in the grey market, but then it is 1 lakh rupees or something like that. So.
Ajay sir, the next question is, what are the specific indications for fixation in children for pot spine?
The indications remains the same. Basically, presence of any instability in the spinal signs, neurological deficit, and deformity. It remains the same. In children, you probably need to be much more aggressive. Whenever you think there is a kyphosis that is happening, because it is a flexible spine, the facet, once it dislocates, the deformity tends to become more. Whenever you think the child deformity or kyphosis tends to progress, it's always important to stabilize. You need not be aggressive over debridement, but stabilization, you may need to be aggressive.
Thank you, sir. So that ends our session for today. So I would like to thank our guest speakers, Dr. Ajay Shetty, Dr. Atul Gogia, Dr. Anvita, and our own Dr. Sunil Katot, sir, and Dr. Tankeshwar, and Dr. Rupinder Chahal. So I hope we did some justice to the topic today. And I would like to thank our partners, Sun Pharma, Mr. Rajesh, Mr. Pawan, Ms. Seema, Mr. Bhatkar. I thank you all for helping us in conducting this webinar every month. And see you next month, second Wednesday again, with the new topic, with the new ideas in mind. Thank you, one and all. Good night.
Thank you.
Thank you.
Thank you very much.
Good night.
Thank you.
Thank you.